Think about what the guidelines suggest. If someone has coronary heart disease, and what should they be on? And
Like a beta blocker?
so definitely a beta blocker, right, to reduce his risk of mortality, and that could also help to lower his blood pressure. Okay, so I'm getting into the weeds. I'm gonna let you guys say more when you get into your case, writing down what you would suggest or what you would discuss with the primary care physician. His dietary habits, he typically eats fast food for lunch 2 to 3 times a week. When he's at work, so he just runs out to Burger King. His dinner is usually home cooked. He says he drinks a beer or 2 after work most days. He had his colonoscopy he had 8 years ago. So, and as far as depression, he's never been diagnosed with it. He did remember taking this test called the PHQ-9, and he got a 6 on it. So this is a little bit jumping ahead of the game, but let's say you're going to do the PHQ-9 when you go through the assessment, and you're going to write down that his score is a 6 on there, okay? So then you're going to decide based on that what you want to do. With all of these findings, you're going to decide how you're going to walk through the protocol and what you're going to say to him, and when you want to see him back, and what you want to say to his primary care doctor. Okay. So his family history, his mother also has diabetes and hypertension, and his mom is not 70 because he's not 48.
Well, that's significant, because a 48-year-old having all these problems
Yeah.
is significantly different than a 68.
Right, no, I know. So you know what, okay, let's just say the photograph is misleading. We'll stick with the fact that he's 48. So that tells you that he's pretty sick, okay? So his father had a coronary heart disease and hypertension and is now died. He died of a heart attack at age 68. So he's 48. We'll just switch his photo out later on. And then he has an older brother who also has diabetes, hyperlipidemia, and hypertension. So he's got a lot of family members affected by these diseases, and even lost his dad. Kind of not extremely young, but still, I would say he died prematurely, because that's not the average life expectancy of a man in the United States, which is typically over age 70. Okay. All right. Sorry about that. So, what are his concerns? Let's see. What slide are we on here? Because I'm going to stop soon. So these are his concerns. He's coming in with abdominal pain and nausea. He thinks he might have eaten something bad that's causing his abdominal pain, but he doesn't want to go to the emergency room now, and he really feels like he can't really afford to take the time off to be in the hospital. So, and then these are some other things about him, his beliefs. After you interview him, you will find out that, once he thinks once you start taking one medication, it causes other problems, which makes you have to take more medicines. He thinks that hypertension is caused by stress and worry. And he feels like he can pretty much skip his medicines when he's feeling good, and it really won't do anything to him. So here are some of his personal issues. So financially, his medications are expensive. So he's on losartan and rosuvastatin, right? He's got to start his new household now because he's gotten divorced. And his stressors, he was divorced from his wife. He's not close with his daughter. We don't know what happens in the family that led to, these problems. But anyway, so like now he's trying to set up a new household. He's also trying to help with his mom, who's kind of struggling with her own medical issues. His work is pretty physically demanding, so he's got to do a lot of like walking up and down and physical work. You know, I don't know if you know about what people in maintenance do, but they've got to climb up on things and try to fix like light fixtures and problems with, you know, doors and windows and all that kind of stuff. So what he does to, you know, with this belly pain that he's been having, he's been trying to just drink water and try not to eat too much. Sometimes he takes ibuprofen, sometimes he takes acetaminophen. He's also tried Maalox for his pain. And like we talked about his diet and exercise already, he doesn't really exercise regularly, but he feels like he's pretty active at work, so he doesn't feel like he needs to do anything more. And again, I said he eats home-cooked meals in the evening, but fast food for lunch. And then, so the doctor, basically when the doctor saw him recently, ordered this laboratory work for the abdominal pain, and basically was planning to refer him to a GI specialist. So he's referred him to the GI specialist, and then he said he would basically see him back to deal with his other problems after he dealt with abdominal pain. So right now he's actually coming to see you. And the doctor at the time said, why don't you just continue your statin and your losartan that you're taking and your baby aspirin, and you know, basically, you know, we need to get you on a healthier diet and all of that, but why don't we deal with this abdominal pain problem first, and then we'll deal with those things. So I think I'm going to stop there. And so what we're going to say is that now, basically, to make this simpler for you, let's just say Mr. Jones is going to see the GI specialist to get his abdominal pain taken care of, okay? So he's got a visit all set up for that. So now that he's coming to see you, he basically wants to talk about, you know, some of these other issues, like his blood pressure and his cholesterol. You know, he wants to talk about some of the other issues that he's been having, his A1C being like 9. And that's really why he got into this program anyway. They told him that he's in this program because, you know, he's got elevated blood pressure, and then he also has diabetes and hyperlipidemia. So he's in this program for that. And, you know, he doesn't need your help going to the GI specialist because the doctor already referred him and he's going to go to that. But he needs to get plugged in to the program for his blood pressure and his diabetes and his cholesterol. So he's coming to see you now. Okay? All right. Any questions before I think what we'd like to do is break into pairs. I don't know if there are enough care managers and community health workers where we could have a community health worker pair up with a care manager. Do we have enough of those, or? So one care manager, community health worker pair. Did Helen and Dorothea had to leave, or Helen left?
Stepped out.
So we could do, we could work in 3s or 4s if you feel like that. Would you feel more comfortable doing that, or?
Yeah.
Okay, so why don't I give you the forms?
So the good news for this guy is the dash tire would solve all his problems. You gotta take the hypertension, the coronary artery disease, and the hypercholesterolemia. There you go.
Alright, then we'll go out.
So, okay. So you've got your form here. And this is the care manager form. You guys can have both. Everybody can have both, so that you can sort of just jot down your notes about if you were talking to this gentleman together,
I got him a call.
what would you document?
This drug.
And then once you get through the assessment, what would you say afterwards that you were planning to do? Just kind of pretend there's like no correct answer, but when you do it, we can talk
Yes,
through
please.
like what your thinking was.
Thank you. Thank you. Thank you. The blue doesn't make sense.
I'm
Sorry, I really did just get him, I have him in my medicine thing.
So yeah, so you guys are just gonna pretend that you're seeing, Mr. Jones, and you're gonna document all the stuff that he has going on, and you're gonna look in your binder for the protocol and kind of figure out what you think you would do with him, okay? And then when you're done seeing him, you're going to, after you complete this, you're gonna look at this form and say, okay, this is what I'm gonna say, this is what we did. This is, we met face to face, you know, like what was his concern, all of that.
No, I understood we filled this out after each thing, but do we also, after the initial visit, do it? Or is it just subsequent visits?
The initial visit too.
Okay.
Alright. So we'll be available, we'll, you know, give you guys a chance to get going and or if you have questions, just let us know, and then we'll also just come around and see what you're thinking. You can talk to each other about what you would be doing with him. Okay. And if, like, some of this is, I mean, these are, cases are based on real people, but unfortunately, I don't know all of them personally, so I wish I could, like, if you say, well, tell me about so-and-so thing, and if I don't know the answer, then you're gonna have to just kind of say, well, this is what we decided, like, he said so-and-so thing, so we decided to do this. You see what I mean? Okay.
Thank you. So the date of the visit is today. Yesterday, 1/17. I don't know what it is. Dr. Who?
Girls not a good team player.
Did you want to vote on the name of the doctor? I just was like moving down the thing.
Confused me. I'm like, what up? What am I missing?
Was this A1C done today?
So we don't know the last time.
I think so. A1C for abdominal pain and repeat lab work to monitor that.
Yeah.
Well, I put that he had the saw the doc a week ago because I figured he said he's already been referred or his appointment was filed. So he's already gotten the results of the lab, so he's already done, since we have the lab. The point is, we don't have to worry about getting another A1C right away because they've had a recent one. So that would be part of the protocol, if they haven't had this stuff, they haven't had it done. Behavioral activation, because I know it says refer for improvement, so it must be the stuff before psychiatric.
But I don't think if you look at, are you guys comfortable with what we did? What you did?
So there's,
So what we did.
that's recommended for people with depression. Like if you look at your options tool.
Yeah, there was things in there for depression.
So there are things like, you know,
But I
engaging more like pleasurable activities.
So that's the
yeah, some of it is like real qualitative, like, tell me what's going on. A lot of times you can have like a meaningful structured conversation and get all the information that you need just by talking to them, right?
Okay, yeah, no, but that's what we were wondering. So that's what
You know, because of course we
Yeah,
can,
so
like, we thought about all
that
those
what we need,
things
but that
that
maybe
ones that we have to connect with right now that can be.
what's like these things like,
I think,
you know,
one of the most important
you
things
could
to him
do
is to figure out
relaxation stuff.
how to
you
help
could
him start
decide
taking
you're
his
gonna start being
medication,
more
right?
physically active.
And then
Plan pleasant activities, you know, so that's what we need.
Okay.
you know, he's down to have a heart attack or a stroke at the moment. You know
And
what I
if
mean?
you can find and compare this to Red Cap system,
Yeah.
so the HW said that they were
And now
educated
he's
going
going
to
to the
nature.
endocrinologist. Well, he needs to come back in 2 weeks.
Where is that? I didn't see anywhere. here.
Right.
About where the
Right.
CHW.
No, the
does.
measure, when they do for,
You know what,
they're supposed to measure.
And
Oh,
have
and if it doesn't, is there a place
if
to
the
one
one
size
size
cup doesn't
then
they have to
if
come
you
to the
have
office.
problems with your pancreas
No, they're,
too.
yeah, but she was saying that they only have the one.
Right,
spot.
right.
So the whole
So I
point
think
is
sometimes
one
when you
spot. Unfortunately, if it doesn't fit, you don't have another option. The idea is to
Yeah,
come
they
every
have to come to the
every day, right.
If it doesn't
But where do we
fit them.
document the measurement somewhere? Where is that documented?
So if we're not, because it's not, relevant and.
But the patients are documented, like on a tracker.
Their arms are covered.
Oh, the arms are covered, so not the measurement of the blood
Well, we
pressure,
have
but
to
the arms.
somewhere to measure why the patients
BID.
monitor your research project.
It's actually okay, I think as long as you document it on this form, which would say, the patient should say,
Doing the home BP check.
I believe I.
It could be
Remember
that
seeing
because
that
of
on
like
here?
comfort having found out, you may not need to go
Yeah,
to the
often you
ER.
may self-monitor.
You know what I mean?
So this is where we
The
put,
provider should
We
be
put
like
not at all,
more confirmatory.
and there should be a
Yeah.
place to explain.
that's what I was wondering.
Is there like an other-
is there like a,
You know, like
in red
have to
in red
file-
cap, is
file
there like a,
with-
there is a comment. that
Should
you
we, like, do a
remember the
comment?
where you can put comment?
Like high and sugar.
Unable to monitor home.
Instead of let.
Yeah, if they're not doing it, well, the cup size, cup
Fitness
doesn't.
style diet, so like you can have a bunch of clear.
So, but do we need to put, do we need to add something about that, or will it
So there's a
automatically
comment
track?
option in red cap.
Like I'm
They just don't hold.
Right, but with regards to
Yeah, we had a drop down box, so if you put not at all,
like calming down those like
patient like that,
just the
behavioral or
maybe that kind of a diet like.
And the one recommendation for hypertension mentions on if they have diabetes, if they have chronic kidney disease. So if their GFR is normal or is okay.
I know, right?
Do you have to go further than
I
that?
went,
For the kidney disease.
I went on.
Not for that, I think the fact that his creatinine, I think what you'd have to know is it like sort of, is this getting worse in some way? In which case you would want to notify the primary care doc to, you know, like stop the info. Or just like make note of the fact that patient's kidney function seems to be not improving, or, you know, when he comes back for it.
If the creatinine is going up.
So, yeah, so I think Katie was showing you some of where they can write down things that they are gonna try to do.
That's the behavioral activation
For under pressure, what kinds of procedures, do you want to reach out to people, do you want to try a new activity, do you want to try to start eating healthier?
So this is something we can get.
I don't know if I can do that.
Give it to them, yeah.
I think that's.
But would they do it? What they always find out something like about what's going on, depending on the patient, you don't think they were talking about.
Even if there were questions, so
We
we
bring
bring
them
my
out
questions
to
to
their
their
open up drinking a lot of liquor. So the most risk for cancer.
Sometimes people find things like this
That's
helpful.
fine.
Some people, like I know my mom is like,
Heart health.
but it's like, it helps her
But
to
apparently,
have something that she can take away, like, so
you know, apparently.
you're talking about something and they, you know, that you,
I
so
like
you
to
can write
think
that down for me.
it's not
Let
every
me
day
write
that I
that
drink
down.
it, so when I do is I can.
Oh, okay, yes,
So we're almost
there. Did you guys have any questions too about different?
Well, certain things we couldn't answer because we didn't have a patient in front of us, so we wasn't trying to, make up anything or be fictitious about it.
But we do have
Yeah,
we're doing our best with trying to emulate it. I mean, ideally, we would have had somebody who's like, maybe an actor, or a young patient who could be Katie.
I would just say.
We wrote down like based on what the patient, so what we did hold off on is the patient's goals because we would want to use the motivational interviewing around to figure out what would work best for him.
Yeah.
And
What do we answer to?
You can tell her about Gloria and I.
a lot of the stuff was about motivational interviewing, like to talk about like the the possible alcohol consumption, talking about that, talking about the medication and why he has issues around that. So that was a lot of us sort of brainstorming how we can best do some motivational interviewing around getting good information about what's the cause and how we can help us.
Yeah.
You can implement like with his mom.
Right.
Saying his mom
And give a whole strain. And we talked about that because he takes his mom to all her appointments, but he doesn't have time for himself.
Because of his job and.
Many people do stuff for other people that they
Yeah.
don't do.
I'm guilty.
I don't know why I'm stuffing her still, but.
Yeah, we are.
Women are.
Syndrome.
Yeah.
All right, well, why don't we just,
Born natural kids.
why don't we take a few minutes to debrief on everything, and then that way you guys can go home for the rest of the day.
Really?
Yeah, and what we're, or, yeah.
Okay.
And then what we can do is, obviously, we're gonna continue working with the case, like, bring him back to see you back in like 3 months, and see where he is then, and then see what you would wanna do at that point, you know?
Yeah.
In terms of like getting a CHW involved, or in terms of getting specialists involved.
One thing we did pick up, Dr. Cooper, is the fact that we feel like he might be a newly diagnosed diabetic because he didn't have it on his problem list, but he had the elevated hemoglobin A1C.
Okay.
So we would want to sort of help him to help the
If he's
provider
diabetic.
to help him to find out what are our next steps to see if he really is diabetic or not.
Okay.
But your next outreach would probably be in like a couple of weeks, right?
Oh, yeah.
Oh, yeah, okay.
I would say for somebody like him, because he's got like so many things going on. And yeah, it would be important to find out if he is not, it doesn't seem like he was on any diabetes medications.
No.
So it did look like he was a newly diagnosed diabetic. And I think our endocrinologist gave us some ideas around what you would do with that. Also, clearly, you know, you've got guidelines around what he should be getting. So he should know that when he goes back to see his primary care doctor, that he's going to be talking about that.
Yeah.
That it's likely that he's going to be put on some medication for a while, and a diet, and, you know, have that monitored. And then if that's not working, he might end up being put on insulin. So he needs to sort of get some heads up about what might be coming down the road, you know.
I was getting ready to prescribe him from that point.
You were just gonna
Yeah,
prescribe it, right? Yes, I know. Well, see, at least you know what to expect. You know what's indicated, right? So how was it going through? Do you feel like that the form is easy to follow? I mean, I think on the one hand, there's the actual seeing the patient and interacting with him. On the other hand, it's the documentation of what you did, so.
I feel like for me, as long as I can figure out how to make it flow as sort of a conversation with the patient versus making it seem so assessment-y, if that makes sense, because I feel like I get a better response when I'm sort of like having an interpersonal thing with the patient, and it's more conversational versus me like asking questions. So I think sort of hitting on this stuff within the conversation, but not so much like reading it verbatim.
Right, I know. Because the form itself is not really a motivational interviewing approach. It's just a document for you to say what conditions he has and what barriers he has, but it doesn't really tell you, it doesn't give you like the flow of the conversation, right? Yeah. So what do you typically do? When you're seeing patients, do you typically just interview them and then you later, after they're gone, you do the documentation, or do you actually document while you're interviewing?
It depends. Some of the stuff that I can document, I'll try to do it ahead of time. So I do like a lot of pre-visit planning. And so, because these assessments are long, like if you really sit and really go through it, it's like a 45, maybe 50-minute assessment. So to knock out some of this stuff beforehand will be great, so that way you can spend more time focusing on the interpersonal piece with the patient and sort of figuring out what's more important for them to work on.
Yeah, I think that makes sense, and I think the form, I'm not sure, but I think it says that some of this could be actually pulled out of the chart, and you could document that, so you're sort of prepared already for what you might need to deal with when he comes in, and then if there are things that you can't find in the chart, you know you need to basically talk to the patient about that. And just also verify some of the things that you found in the chart, but sometimes what's in the chart, we hope is gonna be accurate, but sometimes the patient says, well, no, I didn't really do that, or no, I'm not really taking that medicine, even though it says that on it, you know, so. So, all right, so what did you guys decide to do? Like, which protocols did you feel it like you needed to follow for Mr. Jones? For his hypertension?
All of them.
So, okay.
Hypertension, diabetes, for us to confirm if it's a new onset, his hyperlipidemia, his heart disease, and then nothing for the depression, although we still wouldn't leave it out because he has sort of what we feel like could be some possible role strain around having to care for his mom, and then he just recently went through a divorce. He now has a single income household. He himself is not well, so we sort of wouldn't let that fall by the wayside, but just do a check-in with him mentally to see where he is.
So then when he comes back, you might, or would you consider doing the PHQ again to see where he is at that point? So other than that, yes, so you're gonna be focusing on medication adherence for the hypertension, considering medication adjustment if he is being adherent and his blood pressure is still high. For the A1C, you know that it's elevated, you notice that he's actually not on any medication, so you're gonna try to assure that he gets follow-up, he has follow-up in place, the primary care doctor. Hyperlipidemia, he's had his lipid profile already ordered, he's on a statin, you're just gonna find out whether he's adherent to that, right? Oh, so Mary, I think Mary just joined us.
Yes, thank you.
So we're just going through some of the different health status conditions and what you would be, what the care manager would be reinforcing with Mr. Jones. And it seems like he has almost everything on this form other than he actually doesn't meet criteria for depression. But he's got a lot of like life stressors. So yeah, so there are several protocols that you would be able to follow there, and then you would be basically looking through, documenting some of the things that he's able to do functionally, making sure he doesn't have problems with activities of daily living and things like that that would require you to have an immediate, you know, like step up, for example, to a community health worker or a social worker. So we know he's working, so we know he's pretty much able to function, you know, well. In terms of barriers to care, did you encounter a lot of specific things that were affecting him in terms of barriers to care? Doesn't seem like he has a lot of physical disabilities, no vision problems, transportation issues. Didn't seem to need any kind of a referral for any kind of equipment or anything like that, right? So most of
We
his,
put under the benefit, we just really couldn't find a decent place to put it, but we put under 9H. Do you have any benefit limitations? We put co-pays are too high for his medications.
so maybe if the co-pays are too high, then maybe he might be eligible for some sort of, not a voucher necessarily, but a reduced rate to get his meds filled, or any kind of special programs that might be available through his pharmacy. All right, so then you go through his health behaviors and issues like that. And I think there was a concern of that maybe he was drinking more than what he said. So what thoughts do you have about what he might say on the CAGE questionnaire? So if you went through the CAGE questionnaire, which is questions 16, A, B, C, D, E. And let's say he answered yes to question 16A, he answered yes to B and C, but he answered no to D and E. What would that tell you? Got a score of 2 on the CAGE questionnaire.
Because you really didn't feel like his drinking was causing a problem with this.
So he would feel like it's not causing a problem, right? But do you know what's significant about having a score of 2 or more on the CAGE questionnaire?
Is it early signs of alcoholism?
It is. So that's a screening test for somebody who could potentially have problem drinking. So what we're doing for this project, we're actually going to try to screen out people who are actively like drinking and have alcohol abuse problems.
What do you screen out?
Well, we mean that they're not going to be part of this particular project. But
we call them, we ask them.
we are going to call them,
questions, yeah.
and we're going to ask them these questions. And if they are clearly having problems with drinking, they're probably not going to be part of this project. But some people get in because they might say no on the phone, and then later on, when you see them, it turns out that they are actually drinking more than what they said. So if you suspect that somebody's got a drinking problem, we have put into the protocol some suggestions of how you might intervene and what resources you might use for that. So have you all heard much about brief interventions for alcohol use? So mostly it has to do with, it's a lot of the same behavioral principles that you use with smoking, things about asking people and offering to assist them, so making sure that you refer them to the right resources, so whether it be to a social worker or to a special program for it. And this is all if they are willing to acknowledge that they have a problem and they want to work on it, right? Making sure you have some resources available to share with them, whether it's like Alcoholics Anonymous or, an outpatient program or just talking to a social worker, something like that. But if they don't think they have a problem and they don't want to work on it, there's not going to be a whole lot you can do about that, So I think as long as they're willing to kind of continue to work with them, right?
So I just want to say, I know I talked about this with both groups yesterday, but I think the protocol triggers you to call in for the behavioral specialist office hours if you do encounter someone that you think has substance abuse issues. And so that's another reason why if you're like, I don't really know and I need some more help about how to handle this, you should definitely call in for those weekly office hours and get some feedback from Dr. Antoine about how to handle that.
So that's great. I'm glad you brought that up, Katie, that we actually do have as part of the project that additional resource of a psychiatrist who's part of our specialist group. So if you don't have the resources in your clinic or for whatever reason you're not sure how to handle that, that would be an option for you as well. All right, and then of course you have people talking about like stress levels and depression. We talked a little bit about that with the total health care group. I think you guys brought that up, yeah. Saying that you would definitely try to monitor him, see him back, and then also with your group in the back, you were looking at what kinds of behavioral actions, right? You said, can you tell me which ones? You said you checked off under depression. Behavioral activation, yeah. So, we have resources in the binder where they look like they're materials for patients, but you could actually use them yourself to sort of guide the discussion around ways that they could cope with stress and things that they could do to manage their stress level, even though they're not clinically depressed yet, you know. So I think some of those things included like engaging in more pleasurable activities, reaching out to friends and family who are supportive. I don't know, sometimes it's like signing up for a class, you know, or something that it's something they've been looking forward to doing. Just trying to take better care of their health, eating healthier, getting some exercise. A lot of those things are stress management tools, and they're kind of what we mean when we say behavioral activation. All right, and then I think, so if we continue to move on, Dorethia, we're saying that that they had a hard time filling out the goals part because they didn't have the patient in front of them. So I'm just curious as to how you guys dealt with that part. Did you sort of just have an imaginary conversation?
Well, we said the same thing. This would have to be done with the patient, is
Yeah.
what you said, what they choose. But we kind of said, well, you know, if he'd want to work on his diet, assuming he's compliant with his medication, that would probably address a lot of his things. So we just kind of went, what if that's what he picked.
Yeah. How did you find the tool? Do you think it's something that could be helpful in terms of like helping with specific goal setting with the patient? You can say, I won't feel bad, you know, I'm not gonna, I won't be hurt.
I guess my one thing is as long as I have somewhere to free text some things in. So for example, you know, we put improve his diet because that would address all his different problems. And so one of the ways would be to follow the DASH diet. But on the other hand, you recognize that sometimes if I'm going to be talking to this patient in a week, they're not going to totally adjust their whole diet. But so we'll have little goals. So this week, you know, eat one vegetable a day. And so, you know, some of these little goals, if I had somewhere to break it down.
Right. Okay. So where you see where it says other, you could definitely just do a free text in, so what we'll do is we'll look at the red cap form too and see whether we can make sure that there's spaces for you to just free text things in that aren't specifically what's on the form.
Right, like if he was drinking soda all the time and I wanted to put, okay, so, you know, we cut down to instead of a 2-liter bottle every day, one, you know, things that you might do baby steps.
Yes, no, I agree with you.
And that's good because you know he's getting fast food every day, so you know he probably could be having one of them McDonald's super syrupy iced tea because that tea is super sugary.
$1 and it's cheap. It's $1.
A soda, some of all the sugar in there, because he don't know that he has diabetes. So yeah.
Oh, that sounds great. All right, so so then we get to the end of the goal setting, and then I think there were some questions about on the post-visit form, like where do you record if the patient is not measuring their blood pressure at home, and if it's because the cough actually is too small, you know, and so we want to make sure that there's, again, space for you to put in comments under any question that you have. So, any other issues come up in working through this? That
Do you
we,
feel like the post-visit form could be shortened? You know, like, some of the stuff that they, not looking at it in a direct reader, but some of the stuff, it will naturally have skip patterns.
So depending, the problem is that it's hard to show that on a paper form that there's a skip pattern. But
so if it says, if you answered no to something, there are probably several of these
all
questions that won't
stuff.
come
You
up.
just go to the next thing, for the most part, I think.
Got it, okay, cool. Perfect.
Yeah, but we are mindful of that. I mean, and believe me, we tried to keep this as short as we could. But one of the reasons why it has all of this in it is because we actually have no way of knowing the only way we would have of knowing what you actually did with the patient or talk to them is if we could review the entire electronic medical record, and we aren't gonna be able to do that. So this is our only way of actually finding out like what actually happened.
Okay.
So that's, you know, if the electronic medical record was easier to get the information out of, then we wouldn't have to do this at all, but unfortunately, that's not where we are with technology. And so at the end of the project, if somebody says, well, okay, we see that your care manager and community health worker program worked, and we're really glad, you know, so we think everybody should start like supporting these programs, but we don't know why did it work? What did they do that helped the patients? And we say, well, we don't actually know. The only way that we can find that out is to like go through 2,000 like electronic medical records and try to figure out like exactly what happened. But if we have these, we can say, well, we know that worked because, you know, X% of these patients saw a community health worker and X% of them saw a specialist, right? And the ones who saw a specialist were actually more likely to reach their goal, like within 3 months. And the ones who saw a community health worker, their barriers to care were addressed. So we could be more specific, and it's like, well, which barrier? Well, you know, most of the barriers were transportation barriers. So at least we can at least say exactly what are the issues, because I think one of the reasons why we fail to make progress in this area is because nobody actually knows like what's going on. Everybody's doing the best they can, and we think we have an idea of what's going on, but we really don't know. Like, suppose we find out that most of the barriers are transportation, you know, or that half of them are transportation and half of them are related to the fact that people just don't have enough money to buy their medicines. Well, then we can invest in transportation vouchers and pharmacy vouchers, and that, you know, we will have taken care of like the majority of the problem. But right now, we really don't know. We're guessing about a lot of this stuff, you know? So you'll be contributing to really important information, but to the extent that you find like in the first couple of months that some of this stuff just seems like it's like a waste of time and like nobody's like saying yes to anything, we will be looking too when we get that and be like, okay, we need to simplify this form. We need to like cut out this question because nobody's saying yes to it, you know, or something like that.
My question was is like, question number 3, it says, was patient previously stepped up to a specialist? We have like a separate step-up form, right? Like that we do, or?
So I think that question will actually, it shouldn't really appear on the first visit, but, you know, I think this is for like follow-up. Like basically what you're trying to do is to find out whether this is this a patient who got referred to the specialist group or not, you know? And if so, did you get a response back, and did the primary care provider get that information? Did they act on it, you know? The other way for us to track that would be the specialist form, you're right. The thing is that everybody that gets stepped up doesn't necessarily like get the whole thing taken care of, you know? So this is a way of sort of tracking, well, what happened? The person got stepped up, but like nobody ever discussed it, or it never got back to the primary care doctor. Where was the breakdown, you know? Yeah. But, you know, but I think you bring up a good point. So we'll also go back to our group on this. So one thing we're gonna do before this ends, hopefully everybody will bring their binders on Monday. And what we'll do is make sure the binders are like updated and clear. And then obviously if anything changes between now and the time you start seeing patients, we will definitely like be very clear about what needs to be updated. Okay. So let's see, so are there any other questions, concerns? So tomorrow we're gonna talk again about stepping, like what happens to Mr. Jones. He's coming back, and we're gonna find out what's going on with him from a social standpoint, financial, employment, all that piece. And then we're also gonna find out what's happening with his medical situation, and then determine what would happen if we were gonna step him up to community health worker, and what would happen if we were gonna step him up to the specialist consultation group. All right, is there anything else that I should have covered that we haven't covered today? So what time do we start tomorrow? I guess that's an important thing.
Well, so we usually are supposed to start around 8:30 to have a debriefing of the previous day. We haven't really been doing that. So tomorrow we could do that tomorrow if you'd like, or we could just start at 9, which is when the case study is scheduled.
Today ends at 4? Today. Oh, okay, but
All
we're
right,
ending
so I'll
early.
just-
Okay.
we'll just-